Very good evening to all of you. On behalf of Relisys Medical Device Limited, I want to welcome you all in this evening and a heartfelt thanks to all our faculties and audience who have taken out their valuable time from their busy schedule. Before we commence our today's agenda, let me take this opportunity to take you through the journey of Relisys. With the inspired vision of Dr. Abdul Kalam to make medical care affordable, the company became an independent entity under the name Relisys Medical Device Limited in 2007. The philosophy behind the project was to design, develop, manufacture, and market the high quality medical device in cardiovascular range at most affordable price, thus helping needy patients in India and across the globe. Backed by technocrats and medical specialists, the name Relisys emerged from reliable system, which ensure performance, efficacy, and safety to the patient. The strategic path adopted by the company was to use innovation and cutting-edge technology besides scale of production to achieve product and pricing advantage over competition. Today, we own clean and green state-of-the-art facility built in the more than 12 acres of land, 1,60,000 square feet of built-up area, clean room of more than 60,000 square feet of 10K, HVAC building management system, built as per US FDA norms. Entire facility is certified at ISO 13485 and DSR approved R&D laboratory, fully integrated end-to-end solution for manufacturing stent and catheters. And we take a pride to share that we are one of the largest stent manufacturer in the world. This is a small glance of our factory. With the vision of expansion in 2018, Relisys has acquired Multimedics LLP, a CE mark company, as a part of the expansion plan. This is our vast product range. We have drug-eluting stent like Premier Plus, Pristine Plus, bare metal stent Cobalt C, balloon catheter, Pearl ACNC, angiographic diagnostic catheter Anand, CE mark Des Ensure Ace, guiding catheter Amber, guide extension catheter Access Guide, sizing catheter Squarge, pulmonary artery catheter, Ripacath, transcatheter heart valve, which is tricuspid valve, tric valve, transcatheter aortic valve, which is Vienna, expansion, which are expandable introducer sheath, Relica, which is a microcatheter. We do have a peripheral vascular product range as well. We have Coral, which is a peripheral diagnostic catheter, Advert B, which is a drug-coated PTA balloon catheter, Engross, which is a PTA balloon catheter, Engross HP, a high-pressure PTA balloon catheter, Perinity, a bare metal peripheral stent system, Peripac Ace, a sirolimus eluting peripheral stent system. And this is our new product launch. We recently launched abdominal aortic stent graft, which is AMG Metagraft AAA, thoracic stent graft system, which is AMG Metagraft TAA, cutting balloon Pearl CB, coronary DCB, Pearl DCB. And very soon we are going to launch intravascular lithotripsy. So these are our new product pipeline: central venous catheters, hemodialysis catheter, cover stent, transcatheter valve, transcatheter pulmonary valve, transcatheter mitral valve, endoventral, and CTO recanalization device. And today we are present in more than 55 countries across the globe. With this, let me welcome you all in today's Cardcode Chronicles. This is a webinar series which is dedicated for advancing precision in coronary intervention, where we will witness the evidence-based discussion on integrated Cardcode strategy that is transforming the outcome of the coronary intervention. And let me welcome the facilitator of the evening, none other than Dr. PLN Kaparthi. He is a clinical director of Cath Lab and senior intervention cardiologist from Care Hospital, Banjara Hills, Hyderabad. He is known as a heart expert and renowned cardiologist and a recognized leader in his field. His distinctive approach to patient care is a collaborative relationship in which he educates and empowers the people to take their own healthcare decisions. We welcome Dr. PLN Kapathi, sir. And it's a pleasure and honor to have you today with us, sir. And it's a request that now here you please take the sessions forward, sir. Over to you, Dr. Kapathi.
Thank you, Madhumita madam, for your kind introduction. And first of all, I'm thankful to Relisys industry as well as Madhumita madam for giving this opportunity of educative platform for exchanging the information as well as to know the advanced technology as well as the techniques for giving this opportunity. And first of all, First, I will introduce Dr. Rajesh Kapoor, who is the chairperson for this meeting. And have he joined, ma'am?
Sir, he will be
Hello?
joining shortly. Sir, am I audible?
Okay, okay,
He
okay.
will be joining
Uh,
shortly.
uh, yeah, ma'am. Actually, so can we proceed with the this one lectures?
Yes, yes,
I will
yes.
request Dr. Mondal. He is a renowned cardiologist, and I request Dr. Mondal to present his first case regarding maintaining the vasomotion with DCB lesion from DES and BVS trials. Dr. Debopuriyo Mondal, please.
Good evening, sir. Thank you for introducing me, and it's an opportunity for me to talk in front of such doings in cardiology. And thank you, Relicis, for providing the platform where we talk about the drug-coated balloons and its present-day usage in our cath lab. So mine will be a simple case just to put the discussion in a place where complicated cases can also be discussed. And I will try to reiterate the fact that the vasomotion, which is preserved in drug-coated balloons, is of paramount importance in the long run. So next slide, please. So vasomotion, it is the ability of the blood vessels to constrict and dilate, which is crucial for regulating the blood flow and pressure. And the importance of vasomotion is because of the endothelial function, which is being maintained when we compare this with a drug-eluting stent. So we all know that drug-eluting stents or bare metal stents, when we implant them in the arteries, there is definitely an endothelial damage, which is brought about by the inflation of the balloons and then the metal stent platform, which is subsequently carried forward by the material like the poly D lactate or poly D L lactate, which keeps the endothelium still in a process of injury. And that is why, in the long term, these things can affect the life of the stents. So, when we preserve the healthy vasomotion, it indicates the good endothelial function and it is essential for cardiovascular health. Coming to vascular reactivity, maintained vasomotion allows the arteries to respond appropriately to physiological stimuli, it enhancing the long-term vessel patency and reducing the adverse events. So DCB, DES, BVS, bivascular scaffolds, these technologies are employed in percutaneous coronary interventions to treat the coronary artery disease by preventing restenosis. So any mechanism through which we can prevent restenosis is of paramount importance, and that is where probably the drug-coated balloons have come forward in a big way. Next slide, please. So the lessons which we have learned so far from the DES trials, the initial success with DES, they were successful in reducing the restenosis as compared to bare metal stents by releasing the anti-proliferative drugs like the sirolimus and the paclitaxel. The impact on vasomotion, like the chronic inhibition of the endothelial cell proliferation and the smooth muscle cell migration, therefore impairing the vasomotion. Please go to the slide. So come back to the previous slide.
Yeah, please.
Thank you. So it also leads to delayed healing, long-term presence of polymers and drugs. As I was discussing, this was a paper which was published in JACC in 2008, which told us that these materials, these polymers can delay the endothelial healing, reducing the vessel's ability to constrict and dilate. As a result of which, the clinical outcomes like restenosis, late-stage thrombosis, and vasomotor dysfunction has been subsequently discussed in the ASC Council for Cardiology Practice way back in 2010. Next slide. What are the lessons which you have learned from the BVS trials? Bivascular scaffolds are designed to provide temporary scaffolding and then they resorb, potentially restoring the natural vessel function, including vasomotion. This was the initial promise which bivascular scaffolds had provided. But then the challenges what was faced was the early complications, the increased incidence of device thrombosis in the early trials, like seen in the absorb trial, incomplete resorption, the incomplete and inconsistent scaffold resorption leading to variable outcomes, and mixed vasomotion results. There was some restoration of the vasomotion, but not as consistently, which was hoped from the theory of the biovascular scaffolds. Next slide. So therefore, discussing this background, what are the advantages of drug-coated balloons? Drug-coated balloons or drug-eluting balloons deliver anti-proliferative drugs, mainly paclitaxel and sirolimus, to the vessel wall without leaving a permanent implant. Helps in preserving vasomotion. The temporary drug delivery to the directly vessel wall reduces the smooth muscle proliferation without the chronic presence of a metallic stent. There is no permanent scaffold. Endothelial function, most importantly, is little affected. And the clinical evidence studies have shown that positive outcomes with DCB in maintaining vessel patency and functionality, reduced restenosis rates, and better preservation of vasomotion compared to DES. So with this background, I'll present my case in the next slide. Next slide. So this is one of the diagrams where patients with, this is not my case, patients with single vessel disease, if you do a drug-coated balloon and a drug-eluting stent, it has been definitely shown in the trials that endothelial function is treated, in treated coronary vessels is better preserved by DCBs than by drug-coated stent. So here what we see, a low takeoff right coronary artery with a long segment lesion. And when we give high dose acetylcholine and nitroglycerin, they are significantly reactive. So once we implant a biovascular scaffold, everolimus eluting stent, the reactivity is partially lost as compared to when we implant a drug eluting, a drug coated balloon. The argonovin and the nitroglycerin tests do not become positive. Next slide. So what was seen, there was a favorable vasomotor function after DCB-only angioplasty of the de novo native coronary artery lesion. So once we find out the culprit artery, the argonovin provocation test was done after 6 to 9 months, and it was seen that comparable between DCB-treated and angiographically normal segments. Significant differences are observed against the spastic counterparts. I think simplistically speaking, when we do coronary angiograms after the stented part, we definitely feel a resistance when we inject the contrast as comparison to patients who had DCBs wherein the resistance is not felt. Next slide. So one of my case where I used a DCB 2.5 into 15 millimeter. Play please. So this was one of the acute coronary syndrome where the patient had an angina, and on angiogram it was seen that he had a non-dominant distal LCX totally occluded, and the other coronary arteries, the left system and the right coronary artery, was normal. Next slide. Next slide. So this was a simple case where it was crossed with a workhorse wire, and this was dilated with a, since it was a distal lesion and the diameter of the vessel was around 2.5 millimeters. So definitely my first choice was implanting a drug-coated balloon. So as we all know that usually cut and coat, I utilized a 2.25 millimeter cutting balloon. And after that, I implanted a 2.5 into 15 millimeter drug-coated balloon. And this was one of my initial cases wherein after the drug-coated balloon inflation and optimization, as we see in the subsequent slides, subsequent angiogram, there was a dissection, which was not a flow limiting dissection, but then the distal flow was important to me because the artery was dividing into three important significant branches. And next slide. I think you can appreciate here that there is a dissection flap. So, but the discussion about drug-coated balloons, what we generally tend to see in all the meetings is if there is not a flow-limiting dissection, we can leave it. But I did not have the courage to leave it because the area was, it was an important area and there were three branches. So finally, I had to implant a drug-eluting stent to take care of the lesion. And then finally, what we got was a very decent result. Go to the last slide, final. So this was the final result after implanting a drug-eluting stent. So the whole purpose probably was defeated, but then the important part is when we implant a drug-coated balloon and we see a dissection, which probably in an acute coronary syndrome, see the branches, and it can supply a significant basal portion of the heart. I did not leave it untouched. I was protected with a drug-eluting stent. So this was the final result. Next slide. So the key takeaway messages would be comparison with DES, DCBs offer the advantage of drug delivery without the permanent presence of a stent. Compared with a BVS, it restores the natural vessel function but faced challenges with thrombosis and inconsistent resorption. And in future directions, the ongoing and larger clinical trials, we are now talking about vessels which are 3 millimeter or 3.5 millimeter vessels, de novo lesions, acute coronary syndrome lesions, wherein definitely a lot of data is coming up to utilize the drug-coated balloons. Thank you. Thank you so much.
Thank you, Dr. Mondal, for giving a good presentation. And your intended plan is to coat by drug-coated balloon. But
Yes, sir.
ultimately ended with the drug-eluting stent.
Yes, that is
Am I
the.
correct?
Yes, sir. Yes, sir.
At present, actually, there is a surge of drug-coated balloon from last 2 years from the Western countries, especially European countries, which we discussed in the Euro PCR. The purpose of regaining the vasomotor and positive remodeling, especially. And nowadays, we are only restricted our drug-coated balloon to only instant restenosis or small vessels of 2 to 2.25 millimeters, the two periphery, and the third one is side branch in bifurcation because of the high incidence of restenosis in case of two stent strategy. So now we are doing in these subsets. Unlike
Yes, sir.
European operators who are aggressive in promoting the DCBs, they are even using for proximal LAD, proximal circumflex,
Yes,
as well as proximal RC also.
yes, sir.
But ultimately, the thing is, always remember our initial anatomical result may be suboptimal in case of drug-coated balloon. But by virtue of positive remodeling, as the flaps are healing, always your 6 months and 1 year findings are very, very good actually. So
Okay, sir.
that's why you have taken away with these finding of hazy non-occlusive flaps and you become scared of. You
Sir.
understand?
Yes,
So
sir.
having had you use the drug-coated balloon, maybe after 6 months, what you got the result of drug-coated stent you will get. Because we have also ample number of examples in these type of cases. And the most important, as you told, the cutting or scoring is always better in case of once if we intend to strategy the coated balloon
Yes,
compared to the routine NC balloon. Why? Because the scoring balloons or sculpt balloon or cutting balloon will produce controlled dissections of type A and type B, which are
yes, sir.
non-occlusive,
Yes, sir.
unlike NC balloons which produce occlusive flaps. Another important is when you are intended strategy drug-coated balloon, you should select 1/4 lesser size. Why? Because if you take 1:1 from EL to EL, and another important, whenever you are taking a DCB strategy, take intravascular imaging help. Otherwise, if you take away the image of the angiographic guided, you always produce occlusive flaps and ends with DES. So if you intend to stretch a drug-coated balloon, always take intravascular imaging from EL to EL. Always your balloon should be less than EL to EL. Remember, lumen and EL, you take average. Like OCT is always better when compared to IVUS because IVUS always overestimate your device size, balloon size. Unlike OCT, where you take average and you take lesser size, 1/4 lesser size, lumen and EL sizing, average it. Take that size balloon, both cutting as well as the DGB. You are always your successful is will be good, and always ends with type A, type B dissections, which are the most ideal substrate for coating. You understand? So that is your strategy whenever you intended is DCB.
Right.
So we
Okay,
did
sir.
like we do like that, and we got very good results with the DCBs.
Okay, sir.
Always we won't take NC balloon. Always we will take 1/4 lesser the OCT will do the image. Take the average of EL size and the lumen size of the vessel sizes. and then take that scoring balloons, which are 1/4 size also available. We will score it and then produce a controlled dissections, but the result may not be optimal. Remember, not ideal like DES you won't get. Then we deliver the code the drug, praxidine is the best, and then ultimately we'll get result with the TIMI 3 flows with mild hazy lesion, but still TIMI 3 flows is there. That indicates non-occlusive flaps.
Yes,
So
sir.
your strategy will be like that, so that your success rate of DCB will be more and more. We are
Understood, sir.
increasing a number like that with these strategies, rather than
Right.
ending with it. Understand?
Understood. Yes,
So
sir.
that is the approach you should follow, so that your success rate will increase, and ultimately it serve the purpose. Initially, we start with ISR as well as side branch, osteal, and small vessel. Not like that side branch, large side branches. We won't select that. Suppose if the same light lesion will be there in that one of the OM branches, the most is DCB will end with DCBs. You understand? So these are the more selective in your success rate. In if a DCB program you want to start, so take these tips and take this program. You will be always successful. Once you got the confidence of this one, because some of the operators like Dr. Kukuli and all these they are doing for CTOs, which have become imaged and showing 6 months and 1 year results. He's showing, and he's doing study now with the DCB and in CTOs and in bifurcations also. I think their Europeans are a little bit more aggressive in the DCBs. So maybe once the good trial may come and our perspective may change of cut and coat strategy, or score it and coat it, or sculpt it and coat it. So this strategy is better rather than NC balloon strategy, where uncontrolled dissections and occlusive flaps will develop. Ultimately, it culminates with the DES.
Yes.
Okay.
Thank you, sir.
Very
Thank you. Thank you, sir.
wonderful.
Thank you.
Thank you.
Thank you.
Right.
I have one question.
Next,
I
Dr.
have
Center
I have
Rasa.
one question. So when we go for a bailout stenting, so like the previous case, so after
Yeah.
using a DCB and then going with the DES, so there is always possibility of more exposure with the an inflammatory drug. So neoproliferative drug, is there the chances of any aggressive restenosis or aneurysm formations, which is a concern?
These are all hypothetical. We do not know unless large trials will come, because our operator is like that they are doing, especially large vessel they are doing. For small vessel, I don't think actually that result looks suboptimal. But after 6 months, the result will be very good. I have seen actually this type of ugly. Actually, Dr. Antonio Colombo, he will live like that. We got surprised. Actually, we asked the same question like you. Proximal circumflex, ugly haziness. Usually we will stent it. But unlike he put the deb and he left it. We asked the same thing. Just he showed 1 year after result, he did very good actually. I got surprised actually after saying, but we are not so much aggressive, because now it is a stigma which you have to break that stigma. Stigma is, suppose any one of our colleagues, if you see, don't put the stent, means he will treat as if we did the crime. Understand? So it may take some time unless large trials will come. So that's why we ourselves, as a starting of program, we restrict ourselves to ISRs, osteal side branches, as well as the small vessels, distal small vessels of 2 to 2.25. So because this is class 1 indication, ISR, DEBIs. Whereas for these two, it is 2B indications. So nobody can question you. Once we got the expertise in that one and anticipating with the volumes, then you can mid segment you can switch off. That is fine. Okay, Sevara Saab, any, but very nice Mondal Saab actually. You for your case, even though simple, it is showing a lot of educative. Good evening, Dr. Rajinish ji.
Hi, how are you? Sorry, I got
Fine,
stuck in some case. I'm still in cath lab. Sorry.
Okay, right, Saab, actually.
I just joined.
So
Yeah.
now, previously one case Dr. Mondal presented. Now we are moving to after Dr. Senthil Raj presentation. Anyway, Dr. Rajinish, everybody knows, and he's a renowned interventional cardiologist from Medanta. He doesn't require any introduction. So, can Dr. Senthil Raj, can you present the case?
Greetings, sir. I'm thankful to both Kalpati sir and Kapoor sir for this opportunity. So today I will present my cases of both instant. I have chosen cases only in instant restenosis as it was my topic. So the basic principles for DCB and PCI is to achieve optimal lesion preparation, and then we can achieve this optimal lesion preparation by using any of this. We can use a semi-compliant balloon, non-compliant balloon, or a cutting balloon. So usually we size the vessel balloon diameter to 1:1 to the vessel diameter. And if more adequate lesion preparation is required, we can go with the rotablation lithotripsy and can confirm with the fractional flow reserve. We can use the imaging with OCT or IVUS to know the preparation is adequate. And if we are satisfied with the criteria of no flow limiting dissection, or if the residual stenosis is not more than 30%, or the FFR is more than 0.80%, 0.8, then we can decide on the strategy whether to go with a DEB, and if the criteria is not achieved, we can go for a DES. So we should ensure that we have maintained a short delivery time and a sufficient inflation time is required for a proper delivery. So with this, I'm going towards my case. So the first case is a 72-year-old male. So he's diabetic for the past 15 years, hypertensive, has Parkinson disease. He had an inferior wall MI 4 years back and underwent primary PCA to LCX with 2 stents, and then he underwent a staged revasculation to RCA with 1 DES later. So he presented with the complaints of wrist angina for the past 6 months. He underwent angiogram in another center 3 months back, and it was reported as patent stents in LCX and RCA, and was advised PCA to LAD and RAMUS. Now he came for PCA to a center. So this echo showed hypokinesia in the basal inferior and infralateral territory with a EF of 45%. So this is the angiogram. So the angiogram, the left main appears normal. The ostial LAD has some 60 to 70% stenosis. The diagonal ostium is deceased, and there is a distal diffuse disease in LAD. And the circumflex, the ostium has 80% stenosis. There are 2 discrete stents in circumflex. The proximal circumflex has a Zines 2.515, and the distal circ has a stent of 2.25 into 28. Both the stents are not overlapped. There is a non-overlap segment in between, and the proximal stent has a focal ISR of about 50%. And distal to the stent, it seemed it has a diffuse disease which is visible, and the ramus has a proximal 70% stenosis. RCA has 2 stents. One RCA has ostial plaque, and the Zines 3 into 48 stent appeared patent. So there are distal plaques, PD and PLB is normal. So this is the angiogram. So what's your opinion on this angiogram, and what should be the ideal strategy, sir?
You want that circumflex, this one, ISR.
So actually, the LAD osteomas also has some disease, and circumflex has a diffuse disease. Both there are stents. The stents are patent. Ramus has osteal disease. RCA stent is patent. So now, actually, I thought that we'll leave it for medical management, but the patient has effort angina. So I thought that we should check all LAD, Ramus, and LCX too. I thought that I will check all the 3 vessels for FFR. So this was my first initial plan. So, so what do you think on this angiogram, sir?
No, actually, the thing is already there's an inducible ischemia you documented. So OCT imaging is always important for evaluation of the both ISR, that is most important, whether the pathology is a homogeneous layered or homogeneous non-layered intimal hyperplasia or neoatherosclerotic. This is very, very important actually. But because the duration is short, it is more of neointimal hyperplasia might be more cause. So that your DCB plays a significant role once there is a Neointimal hyperplasia of layered homogeneous or non-layered homogeneous, or heterogeneous layered without a non-atherosclerotic. And of course, osteal also you can see the minimal luminal area and erytheromatous burden. And of course, osteal ramus, you have to evaluate them by imaging. Actually, another advantage of imaging is you can know the size of the balloon and type of device you can select. That is also very useful extra information. Of course, FFR is not this one. It is a synergistic to the OCT. Nowadays, OCT with RFR, it is coming actually, both integrated. So same
Okay.
company actually bought. So that you can simultaneously, along with anatomical evaluation for selection of device, you can know the functional importance of that also with individual territory. So that I think that will, you have to, imaging is mandate in this given case because they had ischemia, but ultimately to identify the territorial distribution. At the same time, once your intended strategy is the intervention, percutaneous intervention, always the selection of device and selection of the size of the device, and along with the functional ischemia, you can evaluate simultaneously. I think imaging is more important before decision making.
Okay. So with this, I thought that as there was a RWMA involved in the inferior territory, I thought that we'll do first a image IVUS to the what is it, LCX, and then revascularize ramus, and then do a FFR to LAD. This was my plan. So I thought that I just started with IVUS to LCX. So LCX was fired, and we did a IVUS pullback. So as soon as the IOS pullback was done, the circ got occluded at the mid L6. Then I had to do a ballooning to open up with a 2 into 15 balloon to open up the vessel. And then this is the IOS. So the IOS pullback showed that a well opposed stent distally. So as it goes forward, so this is the distal stent, which is a 2.25 into 28 stent. So here the stent appears well opposed. So there are some pullback mistakes. And when it comes to this point, there was some under expansion, as we can see that there is a plaque burden beyond the stents. And this is the area where that's not stented. This is the major OIM that is across straight there. This is the proximal LC stent, which is also appears to be grossly underexpanded. Sorry, more opposed, but it's not underexpanded. And as we move forward, so this is the osteal L6, which is not stented. So, and here we come to the circumflex, which has some left main, which has some plaque. So this is the IVUS of pre-IVUS. So the distal reference diameter came around EM to EM was 2 millimeters. The reference lumen area was 2.5 mm. And the stent diameter at the distal edge was around 2 mm. So the 1.8, 1.7 mm. So the stent diameter distal edge measured was only 86% stent expansion. Whether the stent, the distal stent at the proximal edge has had a huge under expansion of about 40%. And when the mid LCX non-stented segment had a plaque burden of around 56%, and the distal reference diameter for the proximal stent was around 3.5 mm, but the stent used in the proximal stent LCX was only 2.5. So, and then the stent diameter at the distal edge of the proximal stent, both at the proximal edge and distal edge had expansion of only 38%. So it was that the proximal stent had a gross under expansion, and the distal stent had under expansion only at the proximal part. So I thought that I will expand the stent first. And so this is the longitudinal view, which shows that the proximal stent has a under expansion and the distal stent has a good opposition and expansion. So then, and as per the criteria, so the absolute MSA should be more than 5.5 square millimeters, and the ideal stent expansion target should be achieved. So for example, if it's a 2.25 stent, So the area expected is around 4 millimeter, and for a 2.5 millimeters, the area expected is around 5 millimeters, which we have not achieved in our case. So, and the reference and the MSA should be at least 80% of the reference lumen area. So I thought that I will expand the stent. So this is being a Zine stent. So the 2.25 to 3.25 stent platforms can go up to 3.75 So, and the proximal LCX also had some plaques, and the plaque burden at the proximal LCX came around 62%. The left main area was good of around 11 millimeters of lumen area, and the plaque burden was around 30 to 40%. So I thought that I will leave the left main and just treat the cell. So this is the optimization of the stents. So both the stents were prepared with NC balloons. The distal stent was treated with a 2.515, and the proximal stent was dilated with a NC balloon of 3.25 into 15 millimeter. So on the distal segment below the OM, I treated with the DEB 2.5 into 40 at 8 atmospheres, and the proximal segment from the ostium I treated with a 3.5. So the left main was around from the ostium, it was from the MLA I got it was 3.5. So I treated with the 3.5 25 at 14 atmospheres. So this is the final angiogram after the treatment. So then I did a post drug coated balloon IVAS. So we can see that the distal stent stent area has improved from 3.2 millimeter square to 5.1, and the proximal stent area has improved from 4 millimeters to 7.4. So there were good stent expansion and good stent areas after the treatment with the drug coated balloon. So this is the IVAS run. So we can see that now the stents are completely expanded and opposed well. So this is the ostial LCX. So then I checked the IVAS to the ramus. So ramus, the distal reference diameter was around 2.5 and the ramus ostium was tight with a block button of around 70%. So I thought that I will do a DCB to the ramus also. So and then I prepared the ramus with the NC balloon, and then I did a DCB of 2.5 into 25 So I'll show the results in the next one. So this is the ramus lesion. And so it was treated with the NC balloon of 2.5 25, and I did a DCB to the ramus. So with that, I stopped. I did not do FFR to the LAD because I thought that as the ischemia is corrected and the procedure went around with I have treated 2 lesions, I stopped with that. So now this is a second case. So second case, it's a 80-year-old female, type 2 DM, hypertension. She had a PCE to LAD with 1 DES 8 years back. Now she came with chest pain for 3 years. Now she had antroval MI. So this is the angiogram. So LAD was occluded from the distal stent. So we can see that there is a thrombus and the LADs are occluded from the mid part of the stent. So as soon as I wired, the LAD was had a flow and with some thrombus burden. So I thought that I will do a IVAS. So this is the IVAS of after a pre-dilatation. So the stent appeared well opposed, but with some overcrowding at the distal edge. But otherwise, the stent expansion is good and the stent is well opposed. So I thought that we'll just do a balloon dilatation and treat it with the drug coated balloon. So this is the reference area came around 3.5. So I dilated with the NC 3 balloon at high pressures, and then I went with the DCB of 3.5 40 So this is the IVAS post DCB. So we could see that there is So the thrombus all had resolved and the stent looked clear. So the only thing which I suggested that the patient would have got a stent thrombosis is that the distal stent must not have been properly post dilated, and there must be some overhanging exposed struts. And the patient stopped antiplatelets for the past 6 months. So that might have caused a stent thrombosis, late stent thrombosis. That is my probable explanation. And so I thought that I will just treat it with a drug-coated balloon. So same way, this is the final angiogram. So there was a small 50 to 60% lesion. So actually that was also treated with the same drug-coated balloon. And this is the stent boost image, which shows that the stent is well uniform and expanded. So the next case was a 76-year-old male, diabetic, had CA rectum. He had bleeding per rectum multiple episodes and had severe anemia. He had PCA 15 years back. Now came with effort angina. The angiogram was done outside, which showed that there was a diffuse ISR of the LAD stent. So we did IVUS actually. I did not add the IVUS as it was time considering the time. So I did it with a cutting balloon with 3 to 10 mm, and then we did a DCB. But even with after doing a cutting balloon, I could not get good results even after post cutting balloon angioplasty. So I thought that considering his high bleeding risk, I thought that I do not want to put a stent in this vessel. So I just did a DCB of DCB and obtain these results. So there is a mild ISR still, which we can appreciate. So considering a very moribund patient, I thought that I will leave this patient with these results. So my take-home message is optimal lesion preparation is essential for DCB angioplasty. So thank you, sir. Thank you.
Dr. Rajanish, any comments?
Yeah, I think Senthil, you have nicely put up your cases. So I think this is, I don't know what discussion has been done prior, but clearly DCB usage has gone up, and it looks, very getting more and more popular. And the indication wise, your instant ISRs or the young patient landing with ACS with only thrombus, less of atherosclerotic block. So, but what I want to say is your initial case, your first case, I don't know whether, see, whether we use DCB, it has to be in a ischemia driven lesion. So I don't know whether those lesions where the underexpanded stent was there, those were also causing ischemia or not. So if yes, ultimately we are trying ischemia. Under expansion or not, I think that we need to address while we are, doing stenting and leaving, giving the final result to a patient. Obviously, we should not under expand. That may have problems, but we don't treat under expanded stents later on chronically until it is giving us ischemia. So that is my only take, that we need to establish ischemia, small vessels, ISRs, side branch osteas, and young patient with more of a thrombotic lesion. The DCB is actually giving us lots of indications where we are now more prevalently using the DCB more and more. Yeah, please go ahead.
Yeah.
Yes, sir.
Dr. Rajanish, Dr. Senthil, very nice case presentations. As Dr. Rajanish already told, apart from the side branch ostia as well as the distal small vessels, ISR, which is a class 1 indication for DCB, and of course, young patient with thrombotic burden and with ruptured plaque, mild plaque and large lumen. And another important high bleeding risk, elderly patient with multiple comorbids and especially end-stage malignancy with high bleeding risk. So these are the subgroups. These are the subgroups where, yeah, you can have these DC expand in this area. Most important. Actually, you have presented correctly, selectively chosen where DC were applied and you fit in the correct way, so that you got very good optimal results actually in these given cases.
Yes,
Nice
sir.
presentation. Thank you. Thank
Thank you,
you,
sir.
Dr.
Thank you.
Senthil.
Thank you for your
Next,
kind words, sir.
Dr. Yeah, Dr. Senthil. And next presentation, Dr. Shirkuri. Hello.
Good evening, sir.
Naveen, Dr. Naveen, yeah, Naveen, please. How are you?
Fine, sir. So, can you see my slides, sir?
Yeah, you are visible and audible, but it's a presentation. Yeah, this is a presentation mode. You have to go, right.
So, this is my case. I have presentation of 3 calcified lesion patients where we end up in using cutting balloon, and one case we have the use of DEB. So, this patient is a 58-year male who present with class 3 angina and breathlessness. ECG shows there's evolved infraval MI, and echo shows there is a mild LV dysfunction with RWM in the infraval, and troponin is elevated, and his HB is 11 and creatinine is 0.9. And this is an angiogram. So there was a osteal tight lesion with a calcified lesion. It was osteal calcified, and there's a tortuosity, and there's a guide support is a major issue while doing the procedure. So we took the JR because I want to stent from the ostium. So if I took the support guide like AL, it become difficult while putting the stent. So I thought I should try to manage with the JR guide. So with the great difficulty, I able to pass the wire. Initially, I tried with the Sheehan blue. It was buckling. So I took the little strength wire. That is the fielder FC I took. So it able to cross the lesion slowly. And once I crossed that even pre-dilatation with the 2 into 10 balloon is very difficult because it's a calcified, so my balloon is unable to cross. So if my initial was I should at least open to, even cutting balloon is little bulky, it has to go. Before that I want to do with the pre-dilatation. So I took the balloon, I started the ostium itself, the balloon is in half, just entry, but majority of the balloon is outside. I tried to dilate from inch by inch technique to forward. So at last I able to dilate both proximal lesion completely. Then I took the cutting balloon. It's a 2 into cutting balloon. I took 2.5. So here so again, the main difficulty was while taking the cutting balloon itself. You see, the cutting balloon was very difficult, but the guide is not supporting at all. So while I pushing it, the cutting balloon, I make sure that this I can able to see the ostium here. So by looking at ostium, though guide is completely disengaged, so I managed with the ostium location with the calcium. Then I dilated with the cutting balloon and make sure it was dilated adequately. Once it was done. Then I took the 3.5 into 18 stent. And then again here also it was great difficulty. Guide support was a major issue. Then the ostium was quite located with the calcium and with while giving injection intermittently. Then we dilated the stent. Then post dilated with the 3.5 12 NC balloon. So here, because it was a calcified and tortuous, so guide support and balloon dilatations were major challenge while doing this procedure. So this was the final result. So the take-home message from this case is, see, osteal lesions with calcified block is challenging with guide support. And wire escalation is important because when it is a tortuous, when any dissection happens with the buckling of the wire, the procedure we have to abandon, we cannot go forward. So by looking at morphology, so as gentle as possible, if possible, little wire escalation is an important strategy. And block modification is important. Without block modification, you can't do a procedure, you cannot achieve a good result. Good expansion is not possible. So you use the block modification where here I can use it with a cutting balloon. And the block modification is a major key in this case. Otherwise, stent passing, the stent tracking is extremely difficult. my second case, this is a 61-year male who present with existing chest pain with class 3 breathlessness. ECG, the ST depressions in 1 AV and V1 to V4, good LV function, and angiogram shows the triple vessel disease. This patient on actually given for the bypass, but on evaluation of CABG workup, she had a left carotid total occlusion with collateral circulation. And so she was advised high risk CABG with carotid endarterectomy, but she refused for surgery. Then we planned initial PTCA for the left system followed by the right system. So this is an angiogram. There is a distal left main block with hostile LAD and proximal LAD tight lesions with calcified lesions there. And mid LAD is okay, and distal LAD there is a mild block with a tortuosity. And circumflex, there's a ostium is okay. Then proximal to distal area, there was a long segment stenosis with the tightest portion being nearly 80 to 90%. So I took the guide with the 3.5 EBU, and I kept both the wires in L8 and L6. Then my first point is I should do the first circumflex followed by the LM to L8 stenting, because there was the distal blocking also there. So this was run of the circumflex. This is a distal circumflex. The lumen area here, the diameter is on 2.5. There's a mild block, and here when it comes to the there was a significant fibroathletic block, and here there is a speckles of calcium in 10 o'clock position, and here again at 12 o'clock there is a small calcium speckles. But when it comes to the proximal circumflex, there is nearly 180 degrees to 270 degrees calcium arc is there. Then followed in the proximal segment again a fibroathletic block. So here again around 90 degrees of calcium from 2 o'clock to 6 o'clock position. This is the proximal circumflex. It's a left main. So here the main based on this, there are at areas of 270 degrees of calcium, and at one area of there's a 120 degrees of calcium. At one area there's a 90 degrees of calcium. So I thought block modification is important here. Then I took the 2.7510 pedal CB cutting balloon. I took the cutting balloon both in the distal and proximal areas. Then after cutting balloon, there was areas of in the distal, I found there's a dissection with the cutting balloon. Then I took the 2.5 into 38 diameter Nagumi stent and deployed in the proximal to distal LCX. Then post-dilated with the 2.758 NC balloon from distal to proximal. And this is the post-stenting I was showing Vela post. Yeah, this. This is a more distal run from distal LCX to proximal. The distal lumen area is nearly 2 to 2.5. Is circumflex. So there was no edge dissection, and there was no major under expansion. This was the angiographic result of LCX. Then my plan was to do the LM to LAD stenting. Then again here we took the balloon dilatation with the 2 into 10 balloon. Then this was the IVAS run in LAD. is a distal LAD. There is a fibroathletic block in the distal segment also, where the areas of tortuosity is there. Here the areas of calcium with around 180 degrees. Here this is the tight stenosis around nearly 360 degrees of calcium. Again, there are arcs of calcium in the proximal segments. This is a thick fibroathletic block. So again, I took the cutting balloon with 3.2510 cutting balloon. So once I took the then post cutting balloons, this was I was run whether the calcium was adequately modified or not. Then I can see some areas of fractures here. Some areas of in the upper 12 o'clock position, there are in the 5 o'clock position, we have the some areas of fractures of calcium. But still here I unable to, but there are some fracture calciums are there in after cutting balloon. This is a fibroathletic block. Then I took the long stent 3 into 44 Ultimaster Nagomi stent. We deployed from LM to LA with mid LAD. And post that with NC distally. Then I took a pot, left main pot with a 4.5 into 8 balloon. Then after this, the IVAS run shows in the proximal LAD, there was under expansion. Here the areas of under expansion. Here again, some under expansion area here. This is the proximal abdomen. So then I took the bigger balloon 3 into, because on IVAS the diameter was only 2.75, but where there was a significant under expansion. So I took the 3 into 12 balloon, though the IVAS diameter is 2.75, but I took the 3 balloon in the proximal segment. Then after dilatation, this was the final IVAS run. So here the stent is expanded well. At areas where the 360 calcium was there, that area still there was a under expansion by around 15-20%. So this was the final angiography picture for post dilatation with the post IVAS run with a good expansion, and there was no edge dissections. So the take-home message from this point of view is the calcified block modification is important for lesion preparation for good results. And cutting balloon here is key in this case, but if I would have used the IVL would have been preferred. But I don't have the financial is the main case because this patient has multiple issues. And the IVAS give because when you are doing the left main intervention, so IVAS is important because the under expansion we need to be addressed. Otherwise, the restenosis is high when we are doing any left main interventions. See the last case. This is a 58-year male who present with retrosternal chest pain. There was ST depression 2-3 AVF and echo. There is no RWM and good LV function. Creatinine and hemoglobin normal. This right coronary is normal. The left coronary there was LCX is subtotal occlusion with the faint flow distally, and LAD, there was a mid lesion, but it was a tortuous, but the vessel diameter is very small. It's nearly 2 mm vessel. Then we crossed LAD. So here the thing was the lesion was not this vessel diameter is small distally. So I want to do first pre-dilatation. If it was no major dissections, then I do only DEB and come out. So I dilated with the pre-dilatation balloon 210. Then I took, there was no dissections. Then I did the DCB with 2.5 12 for 60 seconds. So this was the result after the DCB. Then circumflex, because it was a subtotal occlusion, this faint flow. Then failure XTR of the wire is able to cross the wire with microcatheter support or cell. Then failure XTR, then I can able to cross the lesion. Then I make sure that lesion. Then I took another wire into the OM branch. Then I pre-dilated with the 2 into 10 balloon. Then I dilated with 2.5. Then here again, it was a small branch. The distal diameter is very small. So then I took only DCB and I dilated. Then this was the final result of both LCX and LAD. So here the take-home message is when the lesions are very small, just to put sometimes the small stent, 2 stent, the resistance is very high. So the drug-coated balloon can be useful in these situations. Stent may not be the choice for all the lesions when the lumen diameter is very small and tortuosity, where the smaller stent can higher restenosis, and DCB is a good alternative for stent in these scenarios. Thank you, sir. So this is another case. This patient came with infraval MI, is a ITS male. He had a risk factors like old CV and CKD stage 3, and he presented with ST elevation interval MI. There was a moderate LV dysfunction in ER. The troponin is highly elevated, and his creatinine is 3.2. And because he has infraval MI, so interval MI, but angiogram shows there was a lesions both in OM and LAD, but because interval MI and creatinine is high, so my aim is just to revascularize LAD and come out. But LAD lesion, again, here is a calcified vessel, and there was a distal LAD lesion also. So my aim initially just to revascularize and come out because of high creatinine. Don't want to push much load onto the kidney also. So here the LAD, I crossed with a cyan blue wire. Then pre-dilated with the 2 into 10 and 2.5 10 gradually. Then I took the cutting balloon here, 3 into 5 small cutting balloon with 3 into 5. And I took the stent in 3 into 25 mm stent. Then post there's under expansion on angiographic wise because it is an ischemic patient, so I cannot do imaging at that moment. So I posted with 3.5, and this was angiographically TIMI3 flow with good result. So because I thought of doing DEB in the distally, but because it's a scheme patient, I can't do justice at that moment. So I just revascularize and LAD because the interval MI. So plan for OM stenting later. So thank you, sir.
Thank you, Dr. Naveen. So, Dr. Rajneesh, any comments? Hello? Hello? Hello, madam. Dr. Rajneesh is there?
I think he's facing some challenge, sir. He was just few minutes back
Okay.
also he was there. Just
Okay,
few
madam.
minutes.
So definitely, first of all, I have to congratulate Dr. Naveen for presenting a very complex cases. I want to give some suggestions also. The first case is a very complex case where osteal calcific RC is a different subset actually, where the support is everything from guide to the wires to the devices. So first and foremost, because the JR will give the less support, you can amplify the JR, which is a safer technique compared to the AL. Dr. Naveen.
Okay.
That's number one, which will give a extremely good support. Number two is, of course, your workhorse fire is cyan blue, it seems.
Yes, sir.
And of course, cyan blue is a hydrophilic with a lowest tip load, that is 0.5 grams.
Yes, sir.
So, of course, you find some difficulty, and of course, you change it to filter FC, which is a very, it will cross like anything. Fielder whites, fielder series also, which is a polymer, this one jacket with hydrophilic coating. And whenever you want to predilate, it is not giving support.
Yes, sir.
So always remember, either you take the more support by amplification or by body wire, so that sometimes inadvertently the entire assembly will come in that type of corkscrew type of this one, a shepherd crook type of RCA.
Yes, sir.
So you can take body wire so that you won't find some no difficulty. So wide support or a guide support you have to take. And of course, you prepared very well. And another important calcific lesion with presenting of ACSC's nodules are more common. Very important. You should remember. But luckily, it yielded very nicely with your cutting balloon. Sometimes they won't yield cutting balloon also. Then you have to, like in your second case, where under expanded stent and because of lack of IVL, but you can still manage with OPM. Whenever I have seen actually, where the acute force, in spite of 30 atmospheres, it won't yield. With OPM 16 atmospheres, it will yield, which is a cost effective compared to the IVL. Remember always, Dr. Naveen. So that is most important actually. But luckily, it is yielded with cutting balloon, and ultimately you did very well with the stent. Balloon. I think you put the balloon DCB actual to actual RCA
Yes, sir.
with a very good result. So guide support and body wide supports are needed, which you reduce your adhesion supports in the first case.
Okay, sir.
Coming to the second case, actually, you did very nicely, systematically, both circumflex as well as the manage, which is because it's retro circumflex. Actually, you very well with the your wire and with a good result of circumflex. And of course, LED you did with the cutting balloon, because the aggressive device is needed actually because of cost prohibitiveness. You did not use IVL, or at least if you can do atherectomy in that given case.
Okay, sir.
So under expansion you can avoid, preventable.
Okay, sir.
So especially cost effective is rota, cost prohibitive is orbital. And of course, laser is also cost effective. But laser is a weak atherectomy device compared to the rota, because always laser, you may end with razor. We have seen so many times this type of heavy calcium. So maybe you can prevent, or having had you stented under expansion OPM, cost effective, unlike cost for IVF. So these are some of the suggestions, and of course you did very well, especially small vessels. The most important is deb with after preparation very nicely of non-occlusive flaps. Very nice, Dr. Wayne, of
Thank you, sir.
your complex cases.
Thank you, sir.
Dr. Rajanish, any comments?
Yeah, no, I think I missed out on the total case. I was
Oh,
driving from hospital
sorry,
back home.
sorry.
But
I
yes,
want to
overall,
hear your experience of DCBs and.
so yes. So we are part of one trial. I'm PI in one DCB trial already. I have enrolled 30, 40 patients. So I think even Relicis has come up with a very nice DCB product, which is a paclitaxel coated DCB. And there is always a question which DCB to be used, how to be used. But I think the major point is that DCB indications are growing, no doubt. We tend to put less metal. We are also doing a blended PCI where some vessel is stented and the other small vessel we can have a DCB. Smaller vessels, diffuse disease, and ISRs, side branch osteas, younger patients. So I think yes, that way it is good. The only thing is the lesion preparation has to be good prior to using a DCB. DCB should be the last step of the whole procedure. Prior, you do image the vessel, and then imaging tells you the exact story inside the vessel, whether it is any fibrotic lesion or thrombus or small atherosclerotic plaque, over which the thrombus has happened, or this ISR again, whether it's a neoatheros, everything. So based on that, you pick and choose your devices, cutting balloons or scoring balloons, and then non-compliant balloons. You first prepare the bed well, and then as a last step, take the DCB and inflate the DCB, wait for a minute, that is the best possible strategy, and let the drug percolate into the vessel wall. So I think this we all are doing. So only thing is, try. So if the residual stenosis after using the DCB is high, more than 30%, then it's a question mark. So then I
Yes.
think that is not acceptable. But other
Yes.
than that, if you get a good result and a good flowing vessel, even with some minor dissections are there, that is accepted.
Yes, yes. Thank you. Thank you for giving tips and tricks of DCB program, how we have to develop and we have to expand. Anyway, first of all, I'm thankful to Relatives and Mrs. Madhumita for giving this opportunity of educational platform regarding the DCB and cutting balloon, how the lesion preparatory is useful, how we can expand this area, because all Western European countries, they are aggressive in cageless revascularization balloon treatment. I think Grange Guerra revisited with the DCBs, it seems.
Yeah.
So only thing is we have to probe, we have to expand. That is the only thing. In this program, we should be very careful because, as he told, after lesion prevention, DCB is the last one we have to the step, just deliver the drug and coming out, and which improves the vasomotion. And the most important, the acute result may be suboptimal or it may be ugly looking because our eyes are acclimatized with the stenting and all these things, and we should come out of the stigma, especially whenever there is indicated. You can do the DCB and post, especially by the positive remodeling. I think the results of the long term 6 months to 1 year and even 2 years results also very good with the DCBs. We have seen some of the presentations of renowned operators like Dr. Kukuli and all these who are the very much fan of the DCBs. With this, I express my gratitude to the industry and I will ask any words from the industry. And I'm thankful to Dr. Rajneesh and wishes to the young cardiologist, Dr. Naveen, who is aggressive in this one, and Senthil Raj and
Thank you, sir.
Mondal also for presenting more type of these complex cases, and we'll be very happy actually.
Yeah.
Okay,
Madam,
bye. I take a leave, and congrats to all presenters and analysts. Bye.
thank you,
Thank
Thank
Rajneesh,
you,
for
sir. Thank
your
you.
advice, kind advices.
Yeah, so I will take just 1 minute. So first of all, on behalf of entire Relisys, sir, I want to extend our sincere thanks and gratitude to all our presenter, all our faculty audience. A special thanks to Dr. Kaparthi for your excellent moderation and facilitation of this evening. To all our speakers, Dr. Devupriyo, Dr. Santhilraj, and Dr. Naveen, and of course our chairperson, Dr. Rajneesh Kapoor sir. So we hope that this webinar could able to bring a meaningful and an insightful discussion on the table. And we will continue to do this academic feast and academic series. And we were happy to announce that our next program will be on 21st of March. And today at this point of time, we're very glad to share that nearly 500 plus audience, live audience are there who are connected either from Cath Lab or by online. So it's a great pleasure and honor to have all of you in this platform. And with this, let me conclude the session here. Once again, thank you very much. Good night and happy weekend. Thank you.
Thank you, ma'am. Thank you. Good evening, everybody.
Thank you.
Thank you.